You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape In Discussion Psoriasis. I'm your host, Dr. Steve Feldman. This is the final episode of our second season. We'll be talking about pustular psoriasis, including a hot topic, a chronic orphan condition with a new treatment option, a variant of psoriasis called generalized pustular psoriasis, or GPP for short. How is GPP different from other forms of psoriasis? What population level data do we have about this rare condition? And what do we need to know to manage patients who have this severe form of psoriasis? With me to answer those questions is a leading dermatoepidemiologist whose clinical research focuses on improving the care of patients with chronic inflammatory skin diseases. She has led several multi-site collaborative research projects to better understand rare skin diseases like pustular psoriasis. She's currently an assistant professor of dermatology at Brigham and Women's Hospital and Harvard Medical School. Welcome, Megan Noe.
Thanks so much for having me on the podcast today.
Super. Before we launch into generalized pustular psoriasis, or GPP, let's briefly discuss the more common form of pustular psoriasis, palmoplantar pustulosis, or palmoplantar pustular psoriasis. Is this common?
Generally speaking, it's not. I still consider palmoplantar pustulosis to be an orphan disease, just like GPP.
When you see people with plaque-type psoriasis who have a few pustules of their palms and soles, what do you call that?
Well, that's a great question. I think that's something we're still trying to learn a lot about. When we look at genetic studies, we see that there are key differences between plaque psoriasis, including plaque psoriasis that's localized to the palms and soles, and pustular psoriasis. But in clinical practice, I think we really see disease on a spectrum where we see some patients with just plaques, some patients with pustules, and some patients with a mixture of both. So I think we're sort of still learning the differences between some of these diseases, and that's what can make it a challenge to treat in clinic.
Are all of these variants of palmoplantar psoriasis to pustulosis orphan conditions?
We think about palmoplantar pustulosis as an orphan condition. It's rare based on the epidemiology studies when we use strict definitions of just pustules. But like I mentioned, in clinic, sometimes it can be hard to differentiate. There's sort of more of a blending of phenotypes in true clinical practice.
When you talk about doing the epidemiology and clinically looking for pure pustules, are those prospective studies or are those claims-based studies? What kind of studies are being done to assess this?
There have been some studies in claims databases. I led a large retrospective study that included 20 institutions across the United States and included 10 years worth of data. And I think for rare diseases like pustular psoriasis, you really need to do it retrospectively in order to be able to get enough data in a short amount of time.
So you were reviewing actual chart notes to look for people who just had pustules of the palms and soles?
We did, yes.
Excellent. I sort of worry that when we look at claims databases, that the diagnoses that are listed are based on justifying the treatment we want to give. And if there's no approved treatment, we put down other diagnoses.
I think you're right. I think that definitely happens in clinical practice. Sometimes when you only use a diagnosis code of palmoplantar pustulosis, insurance may reject any of their treatments since there are no FDA-approved treatments. So I agree completely. I think billing codes for these rare diseases may not be completely accurate.
When we have no approved treatments, what do we treat with? Do we treat this differently than we treat typical plaque psoriasis?
Well, our study found that people tried everything that we use to treat plaque psoriasis in these patients with palmoplantar pustulosis. So we found over 20 different treatments used, which really suggests that we as dermatologists, as experts, don't exactly know what to do. And I think in my own clinical practice, that's what I found so challenging, is there's no one treatment that reliably helps all my patients. It's sort of trial and error and finding the right drug for the right person.
My general sense is biologics have revolutionized our management of patients with plaque-type psoriasis. Have they been effective for the people with pustular psoriasis as well?
They're not quite as reliable in pustular psoriasis. So I totally agree. I think in plaque psoriasis, we have amazing medications. They work really well. They're really safe. But in pustular psoriasis, the newer biologics still tend to be hit or miss. For some patients, they can get great results. For other patients, they just don't seem to work.
And that's true for pustular psoriasis in general. We're not just talking about generalized pustular psoriasis.
Right. Both forms of pustular psoriasis.
All right. So how is GPP, generalized pustular psoriasis, different?
So generalized pustular psoriasis used to be considered, or some people may still consider it, a form of plaque psoriasis, but I think of it as its own separate disease. We can see it in people with and without a history of psoriasis, but it really presents different. So patients develop generalized erythema all over. They fall into the category of being erythrodermic many times, and then also have these sterile pustules all over their skin. A lot of times patients are actually systemically ill, and they can have systemic organ dysfunction. And a lot of these patients are actually seen in the emergency room and cared for on the inpatient side.
What will we typically do for these patients since we don't have any standard approach?
Well, we use a lot of the same treatments that we use for plaque psoriasis. So a lot of cyclosporin is used, as that's something that typically works pretty quickly. And like I mentioned, a lot of these patients can be sick and in the hospital. And then we can try some of the biologics, but it may be sort of hit or miss about which biologic will work.
Yeah. So when you say a lot of cyclosporin is used, how do we know that?
Like I mentioned, we did a retrospective study in patients with palmar plantar pustulosis, and we did a very similar study in adults with generalized pustular psoriasis. We collected information about patient characteristics, but also on treatment. And cyclosporin was one of the most used treatments for generalized pustular psoriasis in our study.
Do I have it right that that was the study of nearly 100 patients that you all were able to amass?
Yes, it took 20 different academic medical centers collecting patient data over 10 years, and we were able to get about 100 patients, which really speaks to the rarity of GPP.
And about a third of those patients required hospitalization.
Yeah, so we collected information about all comers, starting at their first appointment at an institution and then following them forward as long as we could. And on initial presentation, about a third of people were seen on the inpatient side.
Yeah, I'm surprised it wasn't higher. And then in that study, about 2 out of 3 patients were treated with internal treatments. I found that shocking that a third of the patient had this horrible GPP and didn't get a systemic treatment. How is that possible?
I think it's possible that because this was a retrospective study, I think we were capturing some people who weren't necessarily in a severe flare and instead presenting to their dermatologist with some symptoms of generalized pustular psoriasis. Maybe they had a history of a more severe flare in the past. One of the things that's tricky about GPP is we know that waxes and wanes, but we don't really understand why and when patients flare. I have patients that will flare frequently, once a year, twice a year. And then there are some patients who will have a flare and then even off treatment won't flare again for several years.
Yes, fascinating. So you mentioned that it may be a different disease and maybe even different genetics. Can you tell me more about that?
The genetics of psoriasis are very complicated, and over 100 different genes in plaque psoriasis have been identified. But the main genes we see that are involved in plaque psoriasis are less important in pustular psoriasis, specifically GPP. And while we haven't identified all of the genetic mutations that are involved in GPP, we have identified one, a deficiency in the IL-36 receptor. And that's not something we see in plaque psoriasis, but is very important in a subset of patients with pustular psoriasis.
I understand that there's families, probably in Japan, maybe more than elsewhere, with genetic defects in the interleukin-36 receptor antagonist. Is that what we're talking about?
Yes, that can lead to a form of pustular psoriasis. Patients tend to present younger. There are even some that present in childhood. And that represents some, but not all of the cases that we see of generalized pustular psoriasis.
Whereas in plaque psoriasis, we're typically thinking about interleukin 23, the TYK2 that mediates the interleukin 23 signal, and then the interleukin 17.
Exactly.
And what with 150 psoriasis genes on one end and interleukin 36 on the other, there's probably a spectrum of involvement so that there may be countless different forms of psoriasis with different propensity to form pustules.
Exactly. And like I mentioned before, when we think about patients with pustular psoriasis, some, but not all, have a history of plaque psoriasis. So those patients might be in the middle of the spectrum, whereas patients with just the pustular form might be on that one end with the IL-36.
There is now an approved drug, spesolimab, for the treatment of patients with generalized pustular psoriasis. How on earth can a drug like that be approved if it took you 20 centers and 10 years to accumulate 100 patients with GPP?
That's a great question. It was an international study performed all over the world. And because this is a rare disease, the way you design clinical trials include less patients than you would if we were studying a drug in plaque psoriasis, where there's lots of patients who may want to participate in the clinical trial.
I understand they had more study sites than they ended up having study subjects.
They did. And I know they enrolled a lot of study sites that never enrolled a patient, but were ready and had the medication so they could if the right patient presented.
It was something like 50 some subjects overall. 2 out of 3 got active drug at first. 1 out of 3 got placebo. One of the things that struck me about the idea of doing a GPP study is that there'd be no way to have a placebo group because you're dealing with people with this horrible condition that you wouldn't be able to put them on placebo. How did they manage that?
So one of the key elements of this trial is actually the study period was only a week. So their drug was so effective that they were able to measure outcomes at 7 days. That's very different than a lot of our other dermatology drugs, and specifically in psoriasis, where we see an outcome at 12 weeks or an outcome at 16 weeks.
Yeah. So another thing about GPP is that back in the old days, when I used to see it more regularly, before we had all these great drugs controlling the plaque psoriasis, we'd have more GPP flare-ups. And back then, you'd admit people to the hospital, you'd put them on some topical therapy, give them the IV antibiotics to control whatever infection might have set them off. If you had cyclosporin, maybe give that, or once we had biologics, one of the faster-acting biologics like infliximab. But these people would get better in the hospital in just a few days anyway. So I was thinking if you ever did try to do a GPP study, the placebo group might clear up too. What did they find in the first week of treatment?
So in this study, they were looking at clearance of pustules at about a week, like I mentioned, and they found that more than half of patients who got the drug spesolimab had clearance of their pustules, and only about 6% of patients on placebo. So there was some placebo response, but not very much.
I understand that most of the patients just got 1 dose of drug. They were allowed to get a second dose. Placebo group switched over. They go on drug after about, 1 week, day 8, something like that?
Yeah, exactly.
And when I see these study results, I always wonder, well, what's the true success rate? One of the things that I consider is what percentage of patients stay in the study? What percentage of the patients need rescue treatment? And it seemed like many more than 50% of the patients did well on the therapy if you use those kinds of things as a measure for failure.
Yeah, I agree. I think spesolimab seems like a great drug for people with GPP.
Anything else we should know about managing patients with pustular psoriasis?
So I think what we know now is this new drug, spesolimab, is highly effective for treating flares. We just talked about how efficacious it is in the 1 to 2 week period. But I think it's going to be really interesting to learn the best way to manage these patients long term. I think of generalized pustular psoriasis as a chronic disease. And so there are ongoing studies now to understand how we should use spesolimab in the long term. Should we wait till people flare? Should we dose it every 4 weeks? Should we dose it every 12 weeks? And we don't know yet, but all of these studies are ongoing. And I think it will be really interesting to learn how often and how frequently we need to treat these patients. I mean, some of our newer biologics for plaque psoriasis are only given 4 times a year, and they keep people clear, which is amazing. And so it will be interesting to see long-term the best way to treat these patients with generalized pustular psoriasis.
I think you may have mentioned early on that these people are sick. They may present in the emergency room. Is there anything we should be thinking about improving the diagnosis and how quickly patients can get started on a treatment like this?
So typically in the emergency room, the most common concern is infection. Do these patients have a concurrent infection? Because like I mentioned, they may present with systemic symptoms, including fevers. So that needs to be ruled out. I think making emergency department providers aware of the disease, which can be really hard because it is so rare. Dermatologists don't see it very frequently. So emergency providers probably don't either. Having dermatologists around and able to evaluate patients in the emergency room is key. I think a dermatologist is really important in making diagnosis of not only generalized pustular psoriasis, but any of these rare skin diseases that present either to the emergency room or on the inpatient side.
I think we should point out that spesolimab is an antibody against the interleukin-36 receptor. And so for those patients who are missing the interleukin-36 receptor antagonist, it's sort of replacing the underlying thing they're missing. But I imagine interleukin-36 being part of that interleukin-31 family might be important for fighting off infection, especially if it's calling in neutrophils. Seems like it would be one of the more basic things you would need for infection fighting. I think in the clinical trial, there was only one serious infection. And if I'm not mistaken, it was a urinary tract infection, which the way I look at things, when I see GPP, one of the first things I wonder is, does this person have a urinary tract infection causing them to have GPP?
Yeah, I think that's a great point. When we looked at our big retrospective study, we did think of infection, and many patients, we identified infection as a trigger for their pustular psoriasis. There was also a concern in the study or a signal for a hypersensitivity reaction. There were only about 50 patients in the trial, so very small number. And so there is a warning on the package insert for a hypersensitivity or dress-like presentation. But when they looked into these cases, they weren't exactly what dermatologists would think of as dress. It didn't meet our diagnosis criteria. But as we treat more patients in the real world, it will be important to sort of follow and see if additional patients develop this hypersensitivity type reaction in addition to their GPP.
Yeah, dress refers to some type of drug reaction. The E must be eosinophilia. The SS,
systemic symptoms. Yes, exactly.
Yeah. And how do you not diagnose dress in somebody with GPP who is, as you described, they're red all over. They've got systemic symptoms because they've got GPP. It seems to me that it would be easy to misdiagnose these patients as having dress when they don't really have it.
Exactly. Lots of overlap in the phenotype and the rash and the way people present.
Excellent. All right. Is there anything else we should know about managing patients with pustular psoriasis?
I think it's important to keep in mind that the old medications still work pretty well. So they don't work quickly, but for certain patients, medication like acitretin, cyclosporin can be reliable. And then, like I mentioned, understanding which biologics work for which patients. So IL-17 inhibitors, generally speaking, can be a little bit more effective than some of the other medications. And then finally, I'm really excited to use more spesolimab and see how that can be a benefit to my patients in the future.
Yeah, hopefully, well, or not, you'll have that opportunity. Being at a major academic center, you might see one. All right, what's one thing you want listeners to do differently after hearing this podcast of ours?
I think the main thing is to identify patients with generalized pustular psoriasis. So even as a dermatologist, we don't see these things very often. So keep in mind, keep it in your differential for patients who present with erythrodermic symptoms, so big red rash all over and pustules. We want to think about infection and drug, but also think about generalized pustular psoriasis because now we have a specific treatment just for these patients that can be highly effective. So we want to start it as quickly as possible.
Super. And if you have patients who have pustular psoriasis and they want to learn more about it, one of the things you can do is direct patients to the National Psoriasis Foundation website, www.psoriasis.org/pustular. Will pull up their pustular information. Let me just summarize what we've learned today. Number one, generalized pustular psoriasis has this enormous impact on patients' lives. As bad as plaque psoriasis is, having severe pustular psoriasis is much worse, more like having hidradenitis. The second fascinating thing about it is we understand to some extent the basic mechanism that interleukin-36 calls in inflammation, in particular neutrophils, and having genetic defects in this interleukin-36 control pathway, not having the receptor antagonist, can lead you to have this generalized pustular psoriasis. Other things can do it too, but if you have this IL-36 receptor antagonist defect, you're going to be more in the spectrum of pustular disease than typical plaque psoriasis. And then the most amazing thing of all is for this rare disease, they managed to do a beautifully well-controlled clinical trial that showed that the spesolimab, which blocks the interleukin-36 receptor, basically replacing the receptor antagonist, gets you rapid control over the disease. Megan, thank you so much for sharing your wisdom with us today.
Thanks so much for having me on the podcast. This was fun.
Thanks for joining our season finale discussion with guest Dr. Megan Noe. Be sure to check out the Medscape mobile app and share, save, and subscribe if you enjoyed this episode. If you haven't heard our earlier discussions about psoriasis management, you can find the previous episodes on the Medscape app. Thanks again for listening. I'm Dr. Steve Feldman, and this has been Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on psoriasis.